For a long time, we have been having we measure our maternal health through the maternal mortality rate. And currently for Kenya, we have approximately 355 maternal deaths per 100,000 live births. And in that, we have not even calculated the morbidity. That is the patients who are experiencing complications. Yet the WHO target, what we call the Sustainable Development Goals, 3.1, actually tells us we should have a target of actually less than 70.
Hello, welcome, Karibu, to the One Health Lens podcast, where we talk about global health and the road to universal health coverage. I'm your host, Dr. Dana Wangari Gitao.
And I am Dr. Simon Moshara Kegondu.
In this episode, we're talking about a very important topic, right? We're talking about maternal child health, right? I was about to say maternal child health care. But a very important topic because 40% of the services Kenyans actually seek out are in maternal child health. So we have a very important guest who will introduce herself before we dive right in.
Thank you so much, Dr. Dana and Dr. Kikondu. My name is Dr. Ruth Wamae. I'm a consultant obstetrician gynecologist. I'm also the National Treasurer of Kenya Obstetrical and Gynecological Society, and I'm also the National Champion for Advocacy at the Society. Okay. And thank you so much for inviting me.
Karibu. I mean, yesterday Kenyans were greeted with the headlines that maternal child health about to be transformed in Kenya thanks to the heat-stable carbetocin, right? And most people ended up saying, okay, what is it, right? Why is it such a big deal, right? I think before we even get into that, maybe let's start off by painting the scenario of maternal child health in Kenya, right? What's happening? What are the metrics we have? Or what are the indicators, right? And then why this becomes transformational.
So that was very, very, very exciting for us in the reproductive health space. For a long time, we have been having we measure our maternal health through the maternal mortality rate. And currently for Kenya, we have approximately 355 maternal deaths per 100,000 live births. And in that, we have not even calculated the morbidity. That is the patients who are experiencing complications. Yet the WHO target, what we call the Sustainable Development Goals, 3.1, actually tells us we should have a target of actually less than 70 per 100,000 live births by the year 2030. But honestly, Dr. Diana, I think for me and Simon, we believe that actually no mother should die while giving birth. So how heat-stable carbetocin is so important for us is that one of our biggest, we have 5 big causes of maternal mortality, and postpartum hemorrhage is the leading, causes about 40% of all the deaths.
What's postpartum hemorrhage?
So postpartum hemorrhage is bleeding after birth.
Okay.
And that's excessive. So excessive bleeding after birth that can cause a patient to be unstable or actually even die is considered postpartum hemorrhage. And there's a way we measure it. So if you lose about maybe 500 mLs of blood during the after delivery, or any amount of blood that will actually cause the patient to be unstable is considered postpartum hemorrhage. And that can actually lead to death after delivery. So having this molecule now available, the heat-stable carbetocin, it's a game changer because it's going to help us manage 40% of our complications because what in other words PPH is causing 40% of those deaths that you're hearing about. So we are very excited and we are so happy that the government has really supported this initiative, and we are happy. We are just happy for Kenyan women. Yes.
Maybe to rope in Dr. Kigondu, right? In terms of your experience, she's talked about one cause of death, PPH, right? What would be the other causes as well, you see?
Yes, so just to make it simple for our audience and those who are listening, pregnancy is one of the states that takes a lot of our healthcare. Yeah. And one of both taking care of the mother and taking care of the dangers that occur as a result of being pregnant or conducting a delivery.
Yeah.
So what we are saying is that the brunt of healthcare problems occur in pregnancy, both to the mother and the child. Hence the importance of maternal, mother and child healthcare.
Yeah.
So ideally, no mother should die from what we normally call unavoidable deaths. They should not die from something that you could have avoided.
Yeah.
And those avoidable causes of death include what Dr. Wamae said, bleeding.
Yeah.
Bleeding when a mother is pregnant can be when they are pregnant, when they are delivering, or after delivery.
Yeah.
Those are the big terminologies that we use. We call it antepartum hemorrhage and postpartum hemorrhage.
Yeah.
Those are big causes of deaths of mothers because, I mean, if you bleed, you will die. So one of the causes, big causes of that bleeding is when the uterus after delivery does not contract. It does not become as hard as a stone. And how we facilitate this is that we give a drug called syntocinon, which helps the uterus contract. Part of the problems that we have seen is that this syntocinon is a fridge drug. And a lot of places where mothers are delivering, there are no fridges, or when it's taken out of the fridge, it loses the strength. And therefore, these, what is now called heat stable carbetocin is a kind of drug similar to that syntocinon that does not get denatured when out of the fridge. And therefore, it will work and prevent bleeding. If I am to use the words of the governor of Makueni during our recently completed Kenya Obstetrical and Gynecological Society annual general meeting, he said, since they have started using this drug called heat stable carbetocin, the people who are the most appreciative are the cleaners. So what does that mean? It means they are cleaning less blood as of before. It means that this drug is very effective and useful. The other causes of death for during pregnancy and delivery include infections, like you deliver and get an infection. Others are complications from abortions. Others include hypertensive related diseases. So people can convulse, a condition called eclampsia, and in some areas another cause is obstructed labor and ruptured uterus. Those would be what are causing our mothers to die, and this can be prevented.
Thank you for that. I mean, even to take a step back, right? I remember I spent some time in Kakamega administering MCH programs, maternal child health programs. And I remember the intervention we had at the time was as simple as being able to provide emergency transportation, right? So that if a mother is about to deliver, they can call a number so that they come to a health facility. But I remember how much we had to explain that, one, the distance that mothers have to travel to get to a healthcare facility in majority of Kenya or Kenyan cities or Kenyan towns is quite a lot, right? Because I think it's always a gap of most people assume that if you're pregnant, since it's not an acute event, right, you already know you have to deliver at the facility. So you will have planned yourself, right? People would assume that the facility would expect that there's a delivery happening maybe in this month, so they'll have the drugs in stock. So maybe the question I'm trying to ask here is the situation on the ground, right? So that people understand why it's such a game changer to have something that doesn't require refrigeration, right? It's heat stable. Why it's such a game changer. Maybe talk about maybe a memorable experience, right? Remarkable experience you've had working out, say, in the counties, right? It could be at any one point whereby you're saying, you know what, we used to work in this facility. What are some of those stories that say this has to happen?
Oh, wow, Diana. I think for me, my first experience of a bleeding mother is something I would call horrific. You know, it is catastrophic to lose a mother. You know, a mother walks in ready to have her child, and even as health workers, you're ready to facilitate a safe delivery and a healthy outcome for the baby. And then you experience a mother who is bleeding after birth. And I remember we gave her, that at that time she delivered a very healthy baby, and after we just couldn't stop the bleeding, and she literally just bled out in front of us. And even you have other issues like even unavailability of even blood products. So when a mother dies, it's catastrophic. I mean, for her, it's complete, 100%. She's died. A baby who is left without a mother is 35 times likely to die within the first 6 months of life. And then her family, that is a spouse who is left with children. Now he has, the responsibilities. He has to maybe leave work, to now take care of this child. The child will be, you have malnutrition, being taken care of alone. I mean, there's a ripple effect. And even in the community, that is a person who could also be working now has left the household. So I think it is very catastrophic to lose a mother while giving birth. And like you're explaining about Western, I think in Kenya we have disparities based on the regions, because we are very diverse. Some people, like let's say in Nairobi, you have the roads, yes, but when you get to the facility, there's an issue maybe with the facility in terms of, are they able to manage with those kind of numbers? In some places like Makueni, it could be the terrain. We have pastoralists. How do you deliver reproductive health to them? So we have a lot of barriers to access care, and some of them maybe even stem from the national level, where you need to strengthen the national policy and guidelines which are guiding the kind of care that is being offered. Because what comes from the National Ministry of Health is now what should aid counties to be able to deliver care in this devolved system. We also have issues like maybe weak procurement systems. Sometimes even our national agencies are not aware about our needs. So maybe they procure things that we don't need, or maybe in terms of the quantities. So it's good for us to keep having a working relationship and a collaboration so that they're able to understand our needs and where we need to work on. And then we also have, human resource for health. We have poor staffing, sometimes even untrained, because they are passing through the colleges and universities and maybe in numbers, or not having enough exposure, to the kind of care that they should deliver. And then we also have sometimes the supervision of health workers. Medical care is an ongoing, even on-job training. Like I can tell you how I left school and what I am now. Sometimes it's
very different.
Yeah, it's very different. It's an element of experience and being supervised and being mentored by the people you find. So we need to also strengthen things like those. And then inequities, which the government can help us solve, whether it's infrastructure, roads, inequities like access in terms of affordability of the healthcare. Is it available? Have you provided doctors in those facilities that you're building? And access to care across all levels of care. Sometimes the care that you get in a level 1 should be the same you should get in a level 6 in terms of quality. Maybe services may be different, but the quality should be equal to Kenyans across the country. And then I think Dr. Simon can help me unpack this. I mean, as a society, we need to we need to appreciate that women have limited rights in this kind of society. So we need to advocate for them to have equal rights like everyone. Sometimes they receive different care based on their social status, their culture.
Come into that.
And just to quote a former past president of the International Federation of Obstetrics and Gynecology, Figo, he said that women are not dying because of diseases that we don't know or we cannot manage. They die because the society has not yet accepted that they are also deserving to stay alive.
Absolutely. I mean, it's a very good point in terms of just the cultural elements, right? And most Kenyans, I think, would recall Linda Mama Project, right? Yes. And at some point, I believe we had high demand because it was, all over the headlines. We were getting, commentary from almost every other county, right? But there was a breakdown in service delivery. Dr. Kigundu, where is that? Where was, not even was the breakdown, but perhaps that can serve as a representation of what else is not working, right?
Linda Mama program was noble initiative. I think the government, which the health workers actually said, one of the items to sort out for someone to get quality healthcare is access.
Yes.
So what does access mean? Access mean the first thing is one of the barriers which Dr. Wamae will talk about more of the barriers is financial access. So the Linda Mama program identified people who may not be able to afford deliveries and paid for them.
Yes.
So for us, that's a good thing. It's what we pursue as a tax-funded health coverage program, meaning that you identify the mother, she's pregnant. When she comes to the hospital, she has been sort of paid for using the tax fund. She has delivered safely and gone home. So there are other elements that go into service delivery other than that access. So now, for instance, once you have brought the mothers to the hospital, are there enough medical personnel to take care of this mother? Are the midwives enough?
Yes.
Are the doctors enough? Then there is the element of supplies. Is heat-stable carbetocin available? Are the other medications which are necessary for safe delivery possible? Do we have equipment? For instance, the baby, when they come out, they need some warmth. Is there what we call a resuscitator? Is it functional? Then is the place clean, hygienic? Is the water availability? So what happens when you increase demand? Then you need to increase also the supply of all other things. The main one mainly is human resources for health, which tends to be static despite all other services being made accessible to the population. So I think that's what needs to be looked at. So the effect of Linda Mama was a workfold increase, 10-fold workforce increase with the same personnel. So if, for instance, one mother was delivering one midwife and the health team were delivering 10 mothers, let's say, for a specific period of time, they became 100 for the same person. So this leads to other issues that, which when measured in terms of service delivery, become a problem.
I mean, speaking of those barriers, right? And I know you have just concluded the COGS meeting, where I believe you did have some senior representation from different counties, right? Could you highlight, for example, which county, give an example? Because what I'm trying to get at is, it's very easy, and we have seen this, right? We get headlines that we now have, a game changer in the market, but it sticks to Nairobi, right? People in counties, how do they procure it, right? How does it translate to the last mile, so to speak, right? So maybe giving the example from the conference to maybe some of the conversations we had with the governor, right? What feedback did you get there, right?
Okay. From our just concluded Congress, we had the privilege of hosting Makueni County and the health team. And the team was led by His Excellency, the Governor, Mutula Kilonzo Jr., and I want to applaud them. I think Makueni County is one of the counties that has decided to take health and its governance very seriously and right from the top. So they have a very great team, and I think it's an appreciation of the importance of health to their constituents, the people live in their county. So they have really been supportive of improving their indicators. They appreciated that they have a problem in terms of delivery of maternal, I would say obstetric, emergency obstetric care, even other obstetric services, and even child health. And they have decided as a team that they will actually work towards improving their indicators. So they attended our Congress and shared with the rest of the attendees about their experiences in terms of what has changed for them when they we worked through a project called Ampli PPHI. It's called Accelerating Measurable Progress and Leveraging Investments for Postpartum Hemorrhage Impact. So in this Ampli PPHI project, we have a consortium of partners, which includes JPIGO, FIGO, and PATH. And one of our objectives was to make sure we have adoption of these new recommendations where the heat-stable carbetocin is one of the drugs. So we have 3 drugs, the heat-stable carbetocin, tranexamic acid, also being recognized as a drug that can be used for bleeding after birth, and the use of even misoprostol for bleeding after birth. So it was to try and have countries adopt these new recommendations so they can be able to improve on their health outcomes. So they have done really well. We've supported them. And they've been able to actually have this drug available in 36 facilities in Makueni. And like Dr. Simon said, once he started using the drug, actually, the first people to notice there was an effect.
Was the cleaners.
Were the cleaners. And they actually even have a name for it. They call it kausha. Because now all of a sudden the floors were dry, the bed sheets are dry because mothers were not bleeding. And they also introduced something we're calling a drip. So there's a recent trial called the Motive trial, which was to use a drip, like something you put it under the mother after she delivers so that you can be able to correctly estimate exactly how much blood she's lost. Because there was also a gap in people were missing. So a mother bleeds, but you cannot estimate. You use your eyes. We call it mature meter. You use your eyes. Dr. Kigondu says it's 200. Dr. Wamae says it's 600. Depending on who saw what.
Subjective,
It depends. Now depends on whether that woman gets the proper treatment for postpartum bleeding. So there has been a lot of introduction of the new innovations in managing postpartum bleeding, and this has really improved. So they want to take the lead, and I think His Excellency told us that we one thing he encouraged us is to, of course, engage with policymakers more. He says that we also confuse them a lot with a lot of medical jargon, and we have decided we are going to take that up as a challenge as health workers, and we want to have conversations that bring solutions.
Absolutely.
Yes. So we are ready. I would like people to learn from Makueni County experience and actually visit them and see the change it has brought.
I want to circle back, I think, also to just the role of, not just girl child, but mother and translation, right? Because I know we're focused a lot on postpartum hemorrhage, but there's much more, right? There's gender-based violence. Even let's take a step back to abortion. There's so many other elements when we even talk about reproductive health, right?
Yes.
And so maybe Kigundu, you could just maybe touch on some of the other elements that are on the forefront, right? That as we're saying that we need to have these conversations with policymakers, we're saying this is a package that you as respective counties need to focus on. What would be other elements?
So I think traditionally there has been some gender inequity in terms of, in several things, both economically and in terms of being in leadership positions and driving policy. Part of this is as a result of the how do you put it? Socialization, and part of it is just the gender roles in society. For instance, if you have two people, a male and a female, doing the same job, and the lady gets pregnant, for instance, then she would probably need some time off to take care of the children. And at this particular time, you may have the gentleman advancing maybe more in that particular role. But the person who has taken time off. So what we have realized, especially as advocates for women sort of empowerment, so to speak, is that you must look at that situation and address the issues that would make the situations that women undergo disadvantage them. You must, for instance, be able to give women paid maternity leave, for instance. There are some situations where they said if you get pregnant, you don't get paid. You see, these are deliberate efforts that you look at what are some of the barriers to development of women. There's even a concept of should we be giving women, for instance, who experience pain during menses, some time of work. You know, it may look like, in quotes, it is normal, but pain actually prevents you from being productive. And worse is the poor management of that pain, which includes making you work when you have pain. So those are small things. Periods. Women may get... some work may get affected when you're on period for various things, both the physical menstrual cycle and also the pain, the emotional changes you get. So as a society, we advocate for deliberate efforts towards ensuring that these characteristics that are unique to women, periods, breastfeeding, deliveries, do not disadvantage the lady. At, for instance, Kenya Medical Association, we encourage women leadership. And if you probably look at our association, it's quite balanced at the top in terms of women leadership. And those are some of the things that we do. And going further, the empowerment of women also helps them recognize gender-based violence. And the first step towards prevention of that is recognition of that. A lot of people went into situations of gender-based violence is that, one, they don't recognize it. Two, when they do, they tolerate it, and maybe they are not empowered to go outside that. And therefore, the deliberate efforts must be made in the reproductive health space to empower women. I'm sure Ruth has something to say about that.
I think so. I'm coming to that because, you know, it's the whole element around. We tend to focus on singular interventions, right? So then we're not addressing the system, right? Because then in many ways it's not just so much it's not just about the drug itself, right? It is the other social, cultural inequities, right? There's the gender bias element, right? Which makes such a huge difference if it's addressing that advocacy policy, right? But perhaps maybe, as Kigondo is saying, you could mention that, right? Beyond the intervention, what have you
I think it brings us back maybe to where we started. Dr. Kigondu had mentioned that about maybe 40 to maybe even more. I believe it could be more. The percent, maybe 40 to 50% of even things, the health services that we offer are offered to women and children. And even if you stand at Dr. Kigondu's hospital in Kigumo and count the number of patients who are walking in there, maybe, you'll find the men come later in life. So women are there throughout the whole continuum. And it's just physiologically we are different. Our issues are different from the men. Some of them develop issues maybe later in life, and when they come in that time you provide the care. So I think it's a recognition that by virtue of our physiology, our health needs and even social needs are different, because our physiological functions now give us other issues, and we need to be understood for that, and asking policymakers, people who are in charge, to include us also in the decision-making process. I think we want to have, it's not a gender fight, it's more of just asking for inclusivity in the decision-making process, and asking the men to be more friendly. You know, you don't have to have, we're not saying it has to be all the people on the table have to be women. We would also like maybe the men on the table to be men who are supportive of women's issues. And I like what you're saying. It's not just one singular intervention. It's a whole system and structure and processes that really, really advantage other people to also thrive in the same situation. Because I think if the women thrive, you know, their families thrive. We live with the men. We don't live alone. You know, they are with us here in the community. Our children will thrive. We'll create better communities. So it's just, I think a recognition and appreciation of the role of women. Yeah.
I mean, and not to sound like an activist, right? But it's not just only recognition, it's us getting those seats on the table, right?
Yes.
I know when we talked about women representation, we have women rep, right?
Yes.
Because I always imagine the first people we want to talk to are the women reps as well. Such that then when we're talking about maternal child health, right? It's not just a health function, right? It now becomes a central political card that they could use, right? I remember having a conversation again with a woman, a nurse actually, in Kakamega. Oh no, actually I confused it. It wasn't Kakamega. I think it was in Isiolo. And we're talking about family planning. And what they were saying is that, of course, because of cultural factors, they cannot be open in terms of them accessing family planning services, right? So they made it a point of ensuring that the one time they have the woman come to the clinic, they almost have a list of things they have to go through. Family planning, there are other elements, because the one time you sit with them, they have daughters, right, as well, who could potentially now come with them. You could address, as Kigondo was saying, right, periods, things that they're experiencing during their teens, right? So it becomes more of a health education promotion kind of package. This one time that you have a chance with the mother, you're talking about anything from teens to menopause, which becomes another factor, right? But then how we translate that to something that becomes a political agenda, right? That could be something we have to address, such that when the women rep are campaigning, right, they're saying, you know what, the platform I'm going to stand on is on this, right? Because they have undergone the experience, right? They can say, I remember when I had my child. I remembered when this, when my daughter, my sister, whoever it is. That becomes a stronger narrative as opposed to then me, Kigondi or OBGYN. But there are some men who it really doesn't make sense why you'd want to take period leave. Why? I mean, it's they wouldn't be able to conceptualize why it's so important, right? Yeah.
So, yes. So championing evidence-based advocacy, SEBA, is a program that both the Kenya Obstetrical and Gynecological Society and the Kenya Medical Association are taking part of. And one of the approaches that they have actually used is using first ladies as the champions of these maternal, child health, and reproductive and nutrition issues in the counties. So just to use as an example, and I think Dr. Ruth Wamae brought with her along Anita Mutula, who is the First Lady of Makueni, to champion this policy on PPH. And what you're saying is that the approach in terms of starting from the governance point of view, yes, if you have lady governors, you can use them. If you have first ladies, you can use them. And women of influence, as you have put it, some of them would be like the women reps. So I think that's an approach that has actually proved to be very effective, because part of the advocacy is not only having them there because they are first ladies, but actually involving them in these advocacy projects, and that has worked pretty well. Maybe Ruth can mention that.
Yes, and maybe also as final remarks, right? What else, if someone is listening to this, right, from a policy maker or someone with influence, right, what would you want them to know, right?
Okay, so just to touch on what he said, is Her Excellency, the First Lady of Makueni County, Anita Mutula, also attended the Congress, and she's a great champion for postpartum family planning in her county. So like Simon has said, use of women, women, they give a face. They, they away from the medical jargon and everything, they give a face to the problem, and they're really championing. They understand the community better, so they are able to communicate to the policy makers. So it's for us, I think for policy makers, what I would ask them to do is listen to the people's voices more. Yeah, you want to deliver something to people, it's good to ask them what they would like and understand from where they are coming from. And that way, the solution that you're going to be providing will be very tailor-made to the community. So I think we have also, in a way, neglected listening to the voices of women, the voices of their families, the voices of their communities, so that we can understand. And asking the women who have leadership positions to really give us that opportunity now that they are there. Even Mutula, His Excellency the Governor, had said that if this problem had been a man's problem, it would have been solved by
Absolutely.
So we are asking the women who get leadership opportunities to really use those opportunities and help us advocate more for women and children, and even the men who are in leadership to support us as we lead. And when they also have opportunities, to not also forget to advocate for women's issues and children's issues. Because I think they really, really bear the brunt of bad governance, especially in health. They really do bear the brunt of poor quality of care.
Absolutely.
Yes.
Absolutely. Kigondu, final remarks?
So if you want to measure the quality of a healthcare system, look at how they are treating the mothers and the children. I became a gynecologist after internship. I made that decision after internship to do two things. To prevent obstetric fistula, which were holes in the genitourinary system that mothers deep in Cumberland were coming with after obstructed labor and sort of neglected labor. So there were many fistulas at that time when we were interns. So I think that was one of my inspiration. And the second one is to prevent what is called cerebral palsy. Cerebral palsy occurs occasionally when there is neglected labor, and then you have what is called fetal distress, and when the baby comes out, then they have undergone a period of lack of oxygenation. And the brain is everything, so they can, at the far end, they can come out dead, like an intrauterine fetal death. At the in between here, there are all those grades of various mental disabilities that occur as a result of something that went wrong during labor and delivery. And if you look at those two, and then you start looking at the monies we budget for health, they are best prevented. Because to take care of an obstetric fistula and a cerebral palsy child takes a toll on both the country, the parents, and the individual.
Absolutely.
So I think we better put our money where our mouth is, which is in maternal and child health.
Maternal and child health. 40% or more of services that are offered in healthcare facilities. I mean, it's such an interesting conversation because, as you say, most of it is preventable. It is literally something that if we focused on, a lot of what we spend treating in facilities, we wouldn't have to expand that money, right? Thank you so much for being here with us. I think it's a conversation we need to continue because it fundamentally boils down to having champions who constantly will be having this conversation, so that it's not just because we have a headline in the paper that we have a conversation, then we forget, then we wait for the next quarter as well. It needs to be continuous conversation. Thank you so much. And thank you for joining us on the One Health Lens podcast. See you next time.
Hello, everyone. I'm Dr. Ruth Wamae, a consultant obstetrician gynecologist. I've been practicing in Kenya since 2008. That could be maybe over 15 years for a while. I do many things. I see patients. I run obstetrics and gynecology clinics. I also practice treatment of infertility. And, I will see patients in the clinic, examine them, make diagnosis, and then eventually for those that need any surgical interventions. On some days I'll be doing surgery. I'll have theatre cases booked, whether it's to remove fibroids or maybe to have hysterectomies for people who are having problems, or even treating infertility. Other than that, I also do advocacy for reproductive health and advancing women's rights. I through the Kenya Obstetrics and Gynecological Society, we run several projects there that help to enhance women's health and their health outcomes. And I'm also the national treasurer. I also keep abreast to the society's activities, just management of the society, where our members include obstetricians and gynecologists spread out through the country within our 7 branches that include Nairobi branch, Central, North Rift, South Rift, Coast, and Nyanza. We support them with, also having advocacy at the county level. And so basically that. And I'm also a mom of a daughter. She's 5 years old. She keeps me busy when I have free time, and she challenges me to do better. Yeah. So that's what I've been doing with my life until now. And I'm asking everyone else to please really help us, in advocating for women's health.